The goals of therapy, simply put, are to have the polycythemia vera be as neutral in the patient's life as possible. And I judge that by trying to decrease the risk of thrombosis and bleeding, improve symptoms, improve splenomegaly if present, and hopefully while having a well-tolerated therapy. An individual who's 75, such as a patient we are presenting, their risk of progression is certainly a minority. In aggregate, P-Vera patients have about a 10 to 15% risk of progression to myelofibrosis. But certainly time is a major factor in that equation, typically people having the disease for 10 years or more. So I'm much more concerned about risk of progression to myelofibrosis in the 40-year-old patient that I saw with polycythemia vera than the 75-year-old individual. All of that said, it certainly can occur at any time. Now, the goals of therapy really first start with prevention of thrombosis and bleeding. That is what we know can cause the greatest morbidity and mortality. It's important that we always keep that foremost in our minds. But in addition to that, we want to be able to control the counts as a surrogate for decreasing that risk of blood clots or bleeding. We want to reverse disease-associated symptoms. We want to control splenomegaly if present. And certainly we need to monitor for evidence of progression. Ruxolitinib is a JAK1 and JAK2 inhibitor. And in polycythemia vera, very cleanly, the overactivation of the JAK-STAT pathway is front and center in the pathogenesis of the disease. So we very much view this as an important targeted therapy that directly has an impact on decreasing that myeloproliferation, with the resulting impact being individuals becoming phlebotomy independent, long-term control of leukocytosis and thrombocytosis, improvement in the whole inflammatory milieu, improvement in symptoms, and reduction in splenomegaly. The clinical trials which led to the approval of ruxolitinib were the RESPONSE study, as well as the RESPONSE 2 study. The RESPONSE study, individuals that had failed hydroxyurea, needed phlebotomies, and had splenomegaly were enrolled on the study, and ruxolitinib was vastly superior to best alternative therapy in control of the hematocrit, symptomatic improvement, and then strong trends were seen for a decrease in thrombotic events, etc. The RESPONSE 2 study was a confirmatory study where it was the same population of people that had failed hydroxyurea who did not have splenomegaly. So really, if the splenomegaly is there, it will improve, but it is not a necessary feature to really see a response. The dose of ruxolitinib in patients with polycythemia vera ranged from 10 milligrams twice a day up to 25 milligrams twice a day. 10 milligrams twice a day is the standard starting dose. Indications for increasing it further would be after an adequate trial at that dose of 3 months or 4 months typically in my practice. If they still have difficult residual symptoms, particular non-fatigue related symptoms, so night sweats, severe pruritus, difficult to control counts such as leukocytosis or thrombocytosis, ongoing need for phlebotomies, then we would go up further on that dosing and then monitor for any toxicities as it would relate in particular to cytopenias. Long-term, the tolerability of ruxolitinib in polycythemia vera has been excellent. And as we presented the long-term data now over 5 years from the RESPONSE study, the majority of patients continue to remain on the drug and continue to be responding and benefiting from the drug.